Welcome to the Best of Posters presentation. My name is Gary Rubin. I'm Assistant Professor of Medicine at the University of Toronto in Canada, and I will be moderating this session. We have three very interesting and exciting presentations for you in this session. Please remember to submit your questions. You can submit them during the presentations as you remember them or following the presentations. At the end of this presentation, we will have an open question and answer discussion. So please send your questions in so that we can make sure everybody's questions get answered. Our three presentations in this session are, the first one is susceptibility to HIV-1 integrase inhibitors in HIV-1 subtype A6 isolates, presented by Alicia Giannini. The second is residual phenotypic susceptibility to second generation NNRTI in multidrug resistant HIV-1 from the Prestigio registry by Francesco Saladini. And the final presentation is 2 drug regimens for the initial HIV treatment, lessons learned from 20 years of the Resina cohort, presented by Nadine Lubke.
Second-generation integrase inhibitors are currently recommended as first-line therapy and have been recently introduced in Russian Federation countries. The study aimed to evaluate the in vitro susceptibility to integrase inhibitors in viral strains belonging to subtype A6, which is the most prevalent HIV-1 genetic variant circulating in Russian Federation countries. Among 81 sequences stored in the Italian ORCA database assigned to subtype A by sequence homology, we identified 20 sequences belonging to subtype A6 through phylogenetic analysis, including A6 reference sequences retrieved from Los Alamos National Laboratory HIV-1 database. Based on plasma sample availability, we created 15 NL43-based recombinant viruses harboring patient-derived A6 integrase protein region. None of the viruses include major integrase-resistant associated mutation, and all but one viruses had the L74I variant, which is the consensus amino acid in sequences belonging to subtype A. We determined the phenotypic susceptibility to dolutegravir, bictegravir, and cabotegravir, and we found that all the viruses had IC50 value comparable to that of the wild-type NL43 virus. 6 out of 15 samples show fold change values slightly higher than the biological fold change cutoff for dolutegravir, indicating a possible minimal reduction in dolutegravir susceptibility. In conclusion, we found that subtype A6 accounted for nearly 25% of sequences previously assigned to subtype A by sequence homology. All the samples considered in this study were susceptible to integrase inhibitors, with a possible reduced susceptibility to dolutegravir in few cases. This data suggests that the susceptibility to integrase inhibitors does not differ from that of subtype B. However, further studies will be carried out to evaluate the genetic barrier to resistance to integrase inhibitors in subtype A6 viruses. The study is based upon work from CARE Consortium that has received funding from the European Union's Horizon 2020 Research and Innovation Programme.
Doravirin is a recently approved HIV-1 non-nucleoside reverse transcriptase inhibitor showing full activity against most single NNRTI mutations and clinically relevant combinations of NNRTI mutations. Previous studies demonstrated that doravirin has a partially overlapping resistance profile as compared to rilpivirine and detravirin. However, a significant cross-resistance has been observed in clones harboring multiple NNRTI mutations. Considering the possible use of doravirin in salvage therapy, we aimed to evaluate the susceptibility to doravirin and the residual activity of etravirin and rilpivirine in multidrug resistant HIV-1 isolate. 22 plasma samples were collected at virological failure from patients infected by 4 drug class resistant HIV-1. We identified major Doravirin resistance associated mutations according to IAS USA mutations list and Stanford HIV drug resistance database. We generated recombinant viruses expressing clinically derived protease and reverse transcriptase coding region, and we measured the in vitro susceptibility to Doravirin, Rilpivirine, and Etravirin. We also compared genotypic and phenotypic susceptibility data according to Stanford prediction algorithm. As indicated in Figure A, median fold change values for Doravirin, Etravirin, and Rilpivirine were 9.8, 42.9, and 100 respectively. At sample collection, 10 patients were receiving Etravirin and 1 patient was receiving Rilpivirine, while 9, 5, and 8 patients had been exposed to 1, 2, and 3 NNRTIs, respectively. As indicated in Figure B, fold change values were higher in patients exposed to NNRTI at sample collection, with statistical significance for Etravirin and Rilpivirine. According to Stanford HIV database and IAS USA list, major Doravirin resistant associated mutation was found in 4 sequences in both cases. Fold change values calculated with Doravirin were significantly higher in sample harboring Doravirin mutations as compared to sample without Doravirin mutations. By comparing genotypic and phenotypic data, emerged that Etravirin activity was underestimated by genotype in 9 cases. According to the biological or clinical fold change cutoff values, residual susceptibility was observed in 5 cases for Doravirin, 4 cases for Etravirin, and 1 case for Rilpivirine, while additional 3 samples had partial susceptibility to Etravirin. In conclusion, in these studies, multi-drug resistant HIV-1 have limited residual susceptibility to NNRTIs. Doravirin retained full activity on a limited number of viruses, indicating cross-resistance with mutations selected by older NNRTIs. In addition, susceptibility to Doravirin may be affected by NNRTI exposure at virological failure. We found that Etravirin activity was underestimated by genotype in nearly half of the cases.
Good afternoon, everyone. My name is Nadine Lübke from the Institute of Virology in Düsseldorf, Germany, and I would like to present you my poster with the title Two-Drug Regimen for Initial HIV Treatment, Lessons Learned from 20 Years Resiner Cohort. The Resiner study was initiated in 1999 in Germany with a total of 38 participating HIV treatment centers in North Rhine-Westphalia for the surveillance of transmitted drug resistance. We currently have access to virological and clinical data from 20 years of documentation. Our objectives were to screen for baseline drug resistance mutations affecting the use of Dovato in first-line treatment and to analyze differences in time to viral suppression of 2DR versus 3DR in the Resiner cohort, depending on the used drug classes. When we take a short look at the characteristics of the cohort, we see that in total 4,815 patients were included, with a majority of men. Overall, 4,219 documented therapies were available, with 4,203 corresponding sequence data. When we look at the baseline viral loads, we see that they were stable over time, with about 60% of patients presenting viral loads below 100,000 copies, and only about 10% of patients with viral loads greater than 500,000 copies per ml. But when we look at the baseline CD4 cell counts, we find a stable decrease of CD4 cells below 200 at the time point of therapy initiation, which clearly reflects the development of the earlier start of therapy in the recent years. A significant decrease is also found when we look at the prevalence of the M184V. While we found this mutation in 60% of the sequences in 1999, the prevalence has dropped to only 15% in 2019. Overall, the prevalence of the M184V at baseline is really rare, with less than 0.5%. Also, the prevalence of integrase inhibitor drug resistance mutations at baseline is very low, with less than 1%. We also looked at the differences in time to viral suppression. First, we looked at differences between 3DR therapies, where we found significant differences between different drug classes. Integrase inhibitor-based therapies showed significantly faster decreases in viral load after therapy initiation compared to NNRTI or PI-based therapies, whereas the comparison between the documented 2DR and 3DR therapies presented no significant differences. In conclusion, baseline resistance to 3-TC/FTC or integrase inhibitors was only rare detected in our cohort. And integrase inhibitor-based therapies showed significant faster time to viral suppression compared to NNRTI or PI-based therapies. Although only few baseline 2DR therapies were documented yet, inferiority to 3DR could not be detected. A 2DR regimen as Dovato could be considered as alternative option for initial HIV treatment. And finally, I want to thank my colleagues in my institute and also all cooperation partners and participating HIV treatment centers, and of course you for your attention.
Thank you very much for those very interesting presentations. We'll now open the session for a question and answer period and invite everybody in the audience to submit their questions to the panelists who are assembled. We'll start off with a question for Dr. Giannini. The A6 subtype has been of interest for some time with integrase inhibitors, but it's really come to light in the Atlas studies with Cabenuva. And interestingly enough, it seems like even though the patients who were more likely to fail with the A6 subtype had some other reason to fail in that study as well, whether it was resistance that was underlying the surface or compliance with medications or anything else. Did you have an opportunity to look at any of those in any more detail as to postulating why the A6 is a peculiarity when it comes to Cabenuva?
Okay. We at the moment we study only the integrase of A6. We must attend the full clone to underline some particularity of this subtype. At the moment, we haven't any other significant information. So we only know that we have this polymorphism, the L741, and no, we start a study for the in vitro selection to check the genetic barrier, but at the moment we haven't any other part of the A6 genotype.
Thank you. A question for Dr. Saladini. In your data, did you look at any changes in Dovato responses with or without the presence of a 184V mutation? I wonder how interesting that would be, because I mean 184V is so prevalent in our HIV positive patients, and it seems not to have a negative effect when we're talking about something like Dovato. And so the opportunities to use Doravirin as a 2-drug regimen may come into play with EFDA and some other medications. So I was just looking to see if you had any difference in the responses with or without a 184V in the susceptibilities with Doravirin.
Well, we didn't check exactly the susceptibility of Doravirin in clones harboring 184V alone, but considering that it's a nucleoside resistant mutation, we expect that Doravirin is active in sample harboring these mutations.
Okay, thank you. And a similar question for Dr. Lupke, but more of, I guess, a philosophical question is, you know, a lot of the debate around 2-drug regimens has been historically 2-drug regimens have never worked. And it's never really been an issue about 2 drugs don't work. It's just never been the right 2 drugs have not worked or not been studied. And it seems that Dovato works well and even better than expected in the presence of a 184V, probably because a 184V prevents the dolutegravir from going down another resistant pathway. So philosophically, where do you think this is going to take our knowledge of antiretroviral medications and resistance in the future? Because it almost seems like Dovato is making a new set of rules for us. I think you're on mute, Dr. Lupke.
Do you hear me? Okay.
Yes, thank you.
Very difficult question. It's really difficult in this situation. We know that this is a very good combination. We have perfect study data. It works really good when we look at resistance. To understand your question, you want to know if resistance still plays a role in these combinations,
or we know that resistance plays a role, but it's just interesting because I think many people on the planet think that Dovato shouldn't work. It's like a Boeing 747 who shouldn't be able to fly, but it does.
Really?
You know,
yes.
And you have a 184V which should knock out your 3TC. So you would say I only have one active drug, but it works because the 184V seems to prevent dolutegravir from going down its pathways, and you almost want people to have a 184V to go on Dovato. And so that kind of thing takes our knowledge of resistance and drug combinations and throws it out the window and say we have a new paradigm here. We have some new concepts that Dovato is introducing to us that, you know, going forward are very, I think very interesting. You know, certainly at this point philosophically.
Yeah. As you said, the 3TC is very interesting because it plays a lot of roles in viral replication cycle, independent of resistance or not. And I think it's quite new, and we don't have a lot of data actually to look if it's normal in 5 years. I don't know, but actually I think it's very important to look for baseline resistance, and as it's not recommended when there is any resistance, but when you don't have the possibility for resistance testing, I think it's very important to know that it works independently in this situation. So 2DR or 3DR, yes, very interesting topic, and I think there was a lot of discussion in the next years about that. Yeah.
Okay, thank you. Do we have any more questions? We have to Francesco. Could you measure a decrease in replication capacity in patients with 184V?
Okay, first of all, I want to say hi to Rolf, and we didn't measure the replication capacity of this sample, but as you can imagine, these recombinant viruses are derived from a sample with also mutation in resistant mutation to nucleoside inhibitors, and we found that most of the samples harboring M184V has a good replication capacity, but I think that this is due to the high number of mutations. So most of these samples harbor also mutation that can restore replication capacity. In the past, in our laboratory, we create mutants. We introduced one 84V mutation in the NL43 sequence, and we found that this mutation reduced dramatically the replication capacity of the virus. So, as already observed, 184V is certainly a mutation that decreased the replication capacity. But in the context of a multi-drug resistant strain, the replication capacity can be higher even in the presence of this mutation.
Thank you very much. I believe that's all we have for questions. So our panelists are getting off relatively easy today. Following this session, there is a guided poster tours, which I would invite everybody to attend. Personally, I find them part of the most interesting aspects of this meeting because you get to discuss one-on-one in close proximity with the authors of some very interesting posters. So I invite everybody to do that. In order to join that session, you need to go back to the live stream, click on the poster tour session, and click on the session that you want to attend. As well, I want to remind everybody that this evening at 8 p.m. Central European time, there is a symposium on COVID-19, and the Virology Education Group has been putting together some very good COVID symposiums lately, and this program as well will be very interesting and insightful and has some very good panelists on it. So please remember to attend that session as well. Finally, in conclusion, thank you very much for attending. For those of you who live in France and Germany who are undergoing a new lockdown, we wish you well. Stay safe, stay healthy, and hopefully we'll see you next year. Bye-bye.